Hello and welcome to this video on immunology challenges and changes, a response to COVID-19. We do hope that you find it useful and enjoyable. Please share your thoughts in the comments and make sure that you like and subscribe so that you don't miss any new content that we upload. So it's now my pleasure to introduce Dr. Ross Sadler. He's a consultant clinical scientist in the Department of Immunology at Oxford University Hospitals NHS Foundation Trust.
Okay, thank you everyone. Thank you very much for coming to listen today. I appreciate everyone is very busy. We're always very busy, I'm sure, but at the moment we appear to be even more busy than we normally are. So thank you for finding the time. And if you're watching this even from a recording later on, again, thank you. I want to talk over this period to try and go over a laboratory's perspective of the COVID-19 pandemic. And I want to be very clear from the outset that I don't want to try and claim anything of the sort that my lab has been right at the coalface of the COVID-19 pandemic. We have not been doing COVID swabbing testing and we have not been doing COVID serology testing. So I don't want to claim any of those really tough tasks as something that we've had to deal with. But I do want to try and bring out some data and show some work in our lab about what we have seen as far as testing and the impact that this has had on screening and immunology condition screening. And then I finally want to finish by talking a little bit more about some of the care pathway developments that we've tried to implement alongside fitting in with the COVID pandemic. So I hope to cover these two things over the course of the seminar. I'll try and do 20 minutes and 20 minutes, see how it goes from there. I'm going to set myself a little timer very quickly because I want to make sure that I'm not overrunning. Okay, so just a little bit about who we are in Oxford. The Oxford Immunology Laboratory is a standalone immunology lab. We are not fitted within a blood science department. We are not fitted within a biochemistry department. We do a reasonable activity for an immunology lab, so about 400,000 to 500,000 tests per year. So again, in the big scale of blood sciences, this is not a very large number. And there are even immunology labs around the country that will do more testing than we will. But what we do have in immunology in Oxford is a very large assay repertoire. So we do, depending on what you define as an assay, we do around 50 to 70 different types of tests. So it's quite broad, and we include all of the immunology platforms that you would find in an immunology lab. So we cover the specialties such as immunodeficiency, we cover allergy, we cover autoimmunity. We in particular cover neuroimmunology as a subspecialty of autoimmunity, and we are an international testing center for this. And we also cover some aspects of hematological malignancy. We don't cover hematological malignancy flow to the level that you would see in, say, leukemia checking. And if anyone is not familiar with our website, that is the link for our website, and please go and visit and you can see our full repertoire that we offer. That's not an advert, by the way. So with regards to what the Oxford COVID situation looked like, we first recorded COVID patients on the 10th of March in Oxford. And actually, if you think back to the history of it, the first lockdown began on the 16th of March. And that's when we had Boris say to us that we were going to be changing our lives for the foreseeable future. And that was at least correct. The OUH at that point decided to halt all non-essential surgery and to effectively close up all outpatient services. The main strategy behind that at that point was this fear that we were about to embark on a very, very large burden of infection in our communities, which was going to require us to have incredibly large numbers of beds available for very sick patients. And very quickly, the OUH made itself have a capacity of around 1,000 beds. And in order to be able to staff all those beds, you needed a lot of medical personnel. And so that meant all the other services started to shut down. And that spread out into the community, as I'm sure you're aware, that primary care then stopped doing a lot of in-surgery appointments, stopped patients visiting the surgery and moved everything to telemed consultation. We as a team made a decision at that point to do split team working. We split our team of about 35 in half, and we usually do a 5-day week, we ran to a 6-day week, and we did 3 times 12-hour shifts, consecutive shifts for 12 hours, 3 times, and then the next team would come and take over for 3 days, and there'd be 1 day of break, and then we'd carry on. And that was a really big change for us. And it was a really big change for a lot of people in the team. We have members of staff who have always worked Monday to Friday in a conventional 7.5-hour day. So this was a big change to how we rotated. And actually, going forwards, I think some of these things, particularly in primary care, telemed consultations are probably never going to leave now. I think they will be there forever. And also in our working, we've now completely changed our working off the back of this. And there are a proportion of my team that now work 10-hour shifts. They work 3.5 10-hour shifts. So they do 35 hours for 3 weeks out of 4 and a 45-hour week out of their 4th week. And so changing the rotas has given us more agility and more flexibility in our working. And I don't think we would have ever made that move if we hadn't have been forced to by this life situation. I want to stress again, we did all of this because our strategy was not because we had to cope with being able to do the PCR testing or the serology testing for COVID-19, but we did have to support the other departments, and we had to be ready to second members of staff out to those departments, and that was run by, the serology was run by biochemistry and still is, and the COVID testing is run by micro. We needed to be prepared to second our staff out, but also we needed to protect that we weren't going to have an intra-department outbreak, and we had to make sure that if we did get outbreaks in our staff, that we weren't going to shut down the entire department. So this was our way of trying to combat these 2 factors. Just to give you an idea of how it looked in the hospital and how it still looks today, I've got 2 graphs here for you. So this is 2 statistics that for me, I felt have been very useful during the COVID pandemic, because this is a personal perspective, but for me, one of the largest and most important metrics to measure how we're coping with this is the burden on the NHS and the burden of how many patients are sick enough that they have to be in the hospital. And so looking at the inpatients that are being admitted who are confirmed with COVID-19, I think gives you a good idea of just how serious things can be. And I've got here a rolling 7-day average statistic rolling through. And so this is starting at the very beginning around the 10th of March and moving all the way through to the 18th of January. And you can see that the first lockdown peaked out at the average was 120 patients in the hospital at any one time. And that was in April. And it then began the decline. And we had this very, very calm period during the summer period from July to October, where the maximum number of patients we had was 8. And unfortunately, we then saw that gradual climb back up. I would argue that this probably coincided for Oxford with our very large student population coming in. We've got 2 large universities in Oxford. And so Oxford City in particular had this huge migration of people coming in. And you can see that just steadily rose and steadily rose. We hit the 120 mark actually on Christmas Day. And we continue to surpass that. And as of the 18th of January, we had a record number of patients in, which was 295. So things in Oxford at this moment are still at a peak, and we are around now still hitting it. I think the highest we've had is 327 on any one day. The other stat I want to show here is a stat looking at, this again for me has been a very useful stat to gain an idea of the indirect measurement of burden in the community with regards to COVID. So this was the staff numbers that had recorded an absence on our absence management system linked with COVID. It doesn't mean all these staff members had tested positive with COVID, but it does mean that they couldn't come to work because either they were being tested and awaiting a result, they were positive, or that they had a family household member who was positive and they were self-isolating, or if they'd been less careful, they had come into contact with someone who now was positive and they subsequently now had to isolate. So any one of those reasons was the reason why they were off. And you can see that actually at the very beginning, we saw an incredibly high amount of people being off from the staff. And I would probably say that that was as much to do with people being unsure about what constituted them not coming to work, and us still as a country and as a world trying to get around the idea of how we should shape these rules. And the rules have changed very slightly over the time period. But again, you can see that it corresponds with what we see in this quiet period, that we got down to as low as 76 staff members, and we've subsequently seen that climb back up to about 650 looking now. So that gives you an idea of how things shape, but what does it look like with regards to testing? And so this is the overall activity for lab immunology, broken down per month and then for the last few years. So what you've actually got here is a graph that shows multiple graphs, all three-dimensionally sitting behind each other. This is not one of those graphs where you've got proportionate increases on the bar charts. So they're all sitting behind each other as you go through. So you can see that this is our total workload per month for everything. It's a rolling 3-month average. And you can see that 2017, and then behind it 2018, 2019 are orange, and 2020 are purple. I make no apology for the garish colours, it's so the people at the back can see very clearly. I tried to do it in really tasteful sub-pastels of blue, and I didn't think it looked good enough, so I've gone for garish. Now, you can see here that, as you would expect, you want to see the later year popping up above it every time, because generally in immunology, as a blood science discipline, in Oxford, certainly, we tend to see a year-on-year increase that's consistent. Certainly for the last 5 years, we've seen upwards of 7 to 10% increase year-on-year of our workload. Now, that's not the same for all blood science disciplines, but certainly for immunology, that's the case. For us, as a lab, in particular, 25% of our total workload is from a secondary care external source. And if you look at that 25%, 20% of it is to do with neuroimmunology testing. So you can see the skew of how our lab model works compared to, let's say, another discipline such as biochemistry. If you're a large biochemistry lab working in a big area, you may have nearly all of your testing may be just from your GP cohort, because you do such a large amount of either acute emergency medicine and GP work that takes up all of your workload, really. Now you can see here that it works very well, certainly for January and February and November, December, but this middle part, there is no purple. If I flick it round for you and show it the other way round, you can see here, if I put the 2020 at the front, so now you can see what that looks like. You can see just how much of a drop we saw from our workload, particularly in April and May and then June. And slowly but surely, we've seen it climb back up again up to where October comes. But still, even in October, we weren't seeing anywhere close to what we were seeing for our 2019 numbers. So things definitely had declined during that time. But what does that look like if we start looking at individual tests? So I've got 3 tests that I want to show you that represent different parts of an immunology service, but they all have one thing in common. And what they have in common is they are screening assays. They're screening assays for conditions which are serious, either in an acute setting, or they're serious in the sense that if you don't proactively deal with them, the patient could face having some level of long-term damage to them. The first one of those from a neuroimmunology point of view I'm going to use is NMDA receptor antibodies. NMDA receptor antibodies can be found in both children and adults. Symptoms of when you have these antibodies can be anything from behavioral change. You can have psychosis develop. You can show memory loss or sleep pattern disturbances, and that can move on to seizures. Now, if these patients are not treated and they have to be treated with quite strong immunosuppressive reagents, then their symptoms will get worse. They will eventually lead to coma and death. So it's quite an important condition to try and identify or understand that there could be an autoimmune element so that you can treat them. So here again, you can see 2020 versus 2018 and 2019, and you can see here that how low we've dropped down compared. So if you see that these orange, the orange here is pretty stable with the 18, but our purple is quite a lot lower. So we haven't seen here a growth. One thing I want to point out is that if we see this reduction in testing happening at these points in the year, we're not seeing that climb up later on in the year, which is the thing that I would be at least happier with, because it would show that we're starting to get this testing performed still during the period of time. Another test I want to show you is Ccp antibodies. So cyclic citrulline protein antibodies have very, very high specificity for rheumatoid arthritis, which is one of the most common connective tissue diseases that you can have. It is a connective tissue disease that is characterized by really inflamed small joints, fingers and toes, for instance, and it has a lot of systemic inflammation involved in it. One of the biggest leading causes of death for rheumatoid arthritis patients is heart disease or cardiovascular disease from that ongoing chronic inflammation. Joint erosion is really bad. It affects quality of life. It's very painful, and it can permanently disable if not dealt with. And early arthritis clinics are usually used in rheumatology, and patients are encouraged to be referred in from primary care. And this test is a great test for being able to show that someone has rheumatoid arthritis, a very strong indicator of rheumatoid arthritis. It's not got 100% sensitivity in any way, shape or form, and therefore shouldn't be solely used, but it is a nice marker to try and pick out for this community. And again, what you can see here is this drop-off of total CCP antibody testing, and we do see some climbing back up, but it doesn't go above what we normally see. Now that is total CCP testing, so that's including all the negatives and the positives, and maybe some that are coming from known RA patients that your rheumatologist may want to check. But if I stratify it and I look at new CCP antibody testing done, so new positives that have been picked out, this is a rolling 3-month average, you can still see the same thing, which is that when we get down to this point here, we see a significant reduction in the number of new positive CCP results being generated. So these are brand new patients, never been tested before, with clinical details saying query RA, or this has been asked for by the rheumatologist in advance of an early RA clinic. And what we don't see again is we don't see that climb back up during this period of time. So these patients that we should be seeing here statistically are not being recouped later on in the year, which is the thing again that concerns me the most about this. My final test that I want to talk about is immunoglobulins. And so I want to talk about this idea of immunoglobulin testing being part of a screen that we use for myeloma. So measuring IgG levels, IgA levels, and IgM levels can actually be used for a variety of reasons. It can be used for immunodeficiency testing. It can be used for patients with known malignancies, such as myeloma, to check their response to therapy and how they're getting on. But also it's used as a first-time screen alongside as serum electrophoresis and urine electrophoresis or serum free light chains to be able to screen for a myeloma. And you can see here again, we do quite a large number of these if you look at the y-axis, but we did see a very significant drop down of what we were normally used to with regards to testing this. Now in Oxford, as a standard, just so this helps with your thought process, we test for every IgG, IgA and IgM level that we measure in our workload. We always do serum electrophoresis alongside it as standard. We don't subgate, we don't check to see whether they should have or shouldn't have a myeloma screen. Everything gets a myeloma screen as standard. That is in part historical. We've always done it, so we've been able to always cope with that workload, but it also fits with our philosophy that we are very intent on trying to find anyone who may have any form of monoclonal gammopathy, where they have a monoclonal protein in their serum, which may indicate they have myeloma. So this is what the total IgG test looks like. What I want to just briefly bring up for you at this point is this idea that when we do find a monoclonal protein in someone's serum from doing something like a myeloma screen, there are multiple outcomes as such as to how serious that monoclonal protein can be. And the most extreme of those is where we would feel the patient needs to go to clinical hematology, and they should be placed on a 2-week wait referral at least. It may be that they're showing such severe metrics that we would actually advise that they need to have that the requester needs to have a conversation with clinical hematology that day to decide if the patient should come in sooner. But we have what we call in our lab outcome 3, which is the most severe risk stratification of those metrics that we find. And what I want to show you here is if we stratify that data that I showed you on the IgG measurements, and which by proxy is electrophoresis screening as well, you can see here just how our number of our myeloma, or our outcome 3 high risk patients with a monoclonal protein, how many we have going through the year. So I've set this up just to try and let you see the ebb and the flow a little bit better this way compared to 2019, because one of the things about looking for these sorts of patients is we do see already seasonal differences in how many we see. I don't have 100% evidence of why this is, but I suspect there are lots of reasons that fit with the normal British calendar. We tend to see, normally this is a common thing we see in years. In January, we can sometimes see this very large increase, which is usually post-Christmas. And I would suspect these are patients who are being very stoic so they can get through Christmas and spend time with their family. And they make decisions in January that they're going to go to the doctors and get this checked up and looked at. And that's when they find, unfortunately, that they've got something quite significant happening to them. We also tend to see drop-offs coming into the period of summer, because we know that patients, again, feel it's warmer, it's more copable. Any symptoms they may have, they may feel they're dealing with, and they're not going to present to their clinicians. So we can see variations through the year normally. But what I want to show you is two things. One is the dip, the magnitude of the dip, again, that we're seeing at this point in the purple, which is our 2020 data. And I also want to show you that there's this recoup that we're seeing popping up at this point later on in the year. So it mirrors it very nicely, but at a lower level. What I guess concerns me again is this point here, where normally around Christmas or coming into the winter period, so October, November, December, it starts to get a bit darker and it starts to get less pleasant out there. Is we do see people start to not cope with their symptoms a little bit more, again, what I perceive to see. And we do sometimes see this inflation. We saw an inflation earlier on in the year, but now that we've gone into a second area of lockdown, we're starting to see this drop down at this point. And what I'm concerned about is if I map this longitudinally going into 2021, where we're still in this lockdown now in January, and we're foreseeably going to see it in February, that we could see a continued decline of finding patients who have got the more extreme versions of myeloma. The outcome of this is going to be that these patients are going to end up presenting eventually. There will be some evidence to say that these sorts of patients demographically may have succumbed to COVID, so that might be the reason why we're not seeing them. But if they do present, this would indicate that they're going to present in a more acute setting. They're going to require much more intervention to stabilize them because they've got worse. Why have they got like this? Unfortunately, I suspect this is because there is, we are generally putting out a message that says, don't go to your doctors unless you have to, don't go to A&E unless you have to, don't go to GPs unless you have to. Certainly in the first lockdown, that was the message we gave. We've tried not to, I think, as much this time around because we've recognized this, but it still has an effect. And this is what we can see from it. So that's the first half of my talk, just to show you some data to talk about how the testing has changed and why this is an atypical year that we've just had in 2020 and what that could impact and lead to. What I want to talk for the second part of the talk is I want to discuss a development of a care pathway, which very nicely leads on from the myeloma work I've just shown you. And to give you some history about this, I'm just going to give you some data, a bit of a story about it. So in 2017, 2018 time, the local medical committee, which is the LMC, which is a representation group for GPs, and there are many of them regionally around the country. The Oxfordshire LMC approached the OUH and they approached the Oxfordshire CCG, and they asked for a solution for the monitoring of various conditions. Now, two of those conditions they wanted to ask for was CLL and MGUS. And the issues that they had, or the GP community felt they had, was they had particular issues with being able to schedule the monitoring bloods that were taken for patients who had very low risk versions of monoclonal gammopathy or chronic lymphocytic leukemia. So if we find any patients who have the monoclonal proteins in the myeloma screen, I said we put them into risk stratification, and I've shown you the extreme version. If we go to the lowest risk version, often we would say to them, they don't need to go into secondary care, they can stay in primary care and they can be monitored by a GP, and they should have regular bloods to be taken. And when I say regular, I'm talking anywhere between 3 monthly up to yearly bloods taken so that they can be constantly checked, because evidence shows that if you have a monoclonal gammopathy of any size, time is the factor of when it will progress. So will it progress? Most likely yes, but the question is, how long will it take until it does? And will you not die of something else, probably old age, before that happens? And that can be the argument for it. So if you're an 85-year-old and you find a monoclonal gammopathy in your patient at 85 and it's low risk, the chances of them progressing to a severe version such as myeloma is quite low, because their life expectancy would not mean that they're going to survive long enough. If they're 50 years old when you find the MGUS, then actually you've got potentially 30 years for that patient to now progress. So there are a lot of justifications for monitoring these patients and keeping an eye on them, as well as the fact that patients with MGUS statistically do worse than their demographic counterparts who do not have a monoclonal protein. And that's with regards to infection, with regards to organ failure, with regards to thrombotic events, and with regards to osteoporotic fractures, particularly vertebral fractures. So monitoring MGUS is worthwhile, I believe. Not everyone believes that. But also monitoring has to be organized quite well for it to be effective. I can say anecdotally, even before I had this seminar, unfortunately, my team are phoning out a patient who has just arrived at the Horton Hospital in Banbury, and unfortunately they have succumbed to a serious fracture because they had a monoclonal protein identified 2 years ago, and they haven't been monitored for 2 years, and that has now progressed significantly. And so this is a missed opportunity. It doesn't mean that we haven't advised monitoring, but the monitoring has not unfortunately been performed. And this is where this issue came from with the GPs. They said they were having trouble being able to schedule the monitoring. They didn't feel they had IT to support it. And secondly, when they were having the monitoring bloods taken, they didn't feel equipped to be able to interpret those monitoring bloods effectively, or to be able to make the correct decisions of when a patient should be referred to hematology. So laboratory immunology and clinical hematology spoke and talked and worked together to try and come up with a solution to this problem. And what I want to really bring out here is this idea that during COVID and during 2020, I'm sure everyone hopefully is listening to this would agree with me. Unfortunately, all those projects that you had, that you were sitting around Christmas 2019 and you were going, right, it's New Year, it's January 2020, going to hammer those projects this year. We're going to get all these things sorted. This is a really motivated year. Let's do it. You did it for about 8 weeks, and then the world just completely changed and all your priorities went out the window, and you had to start all over again with what you thought was important. And that's exactly how we were as well. So this project that had been going on in 18 and 19, this trying to find a solution, trying to work out a way of designing it, got really put into a position where it was being scrutinized as, should we bother doing it? But what we evaluated about this was the idea that actually this project or this development was something that was going to be a double bonus. Not only was it already going to help the situation pre-COVID, but during the pandemic and the new way that healthcare looks to be running, or how we want to make healthcare run in a pandemic, this was going to be a double bonus. We wanted more patients to be spending time in the community. We wanted more patients to be reliably monitored. And we wanted this to be a way that was not going to burden secondary care too much or the GPs too much. So this was our aim, to try and put energy into this to try and get the benefits into the system. So what I'm going to try and do now is show you this algorithmically, how this works and the mechanisms of how this works for you. So you should hopefully be able to see a nice algorithm now. So the way that this pathway works is, first of all, when it comes to the monoclonal gammopathy pathway, lab immunology is the beginning of that investigation, because you start a myeloma screen by finding the immunoglobulins and the electrophoresis and the serum free light chains and the urine electrophoresis work to be able to identify if a patient has a monoclonal gammopathy. Once we find that, we do risk stratification, and we're going to put them into one of 3 groups. So this is the lab team the healthcare scientists and the medics who are working together, looking at that data to come up and say, we've risk stratified the patient into one of three categories. And if they're really high risk, as we've already identified, outcome 3, then that user will get contacted. They'll go to a heme consultant clinic on a 2-week wait. That patient's either going to then undergo treatment, or they're going to be monitored by the myeloma CNS team, and they're going to stay on the books of clinical hematology at that moment. If we feel that they're not quite as serious as that, but we're not happy to put them just out into the community, then they may go into a medium risk category. And actually what we're going to do here is we were going to use something we developed called OxCom, and we did this in collaboration with the CLL pathway. And this is effectively a telemed consultation service with a set hematology nurse who can get in contact with the patient and have a follow-up appointment with the patient just to check and run through a few things with them, as well as having those metrics that we've picked up. And we see this in the first instance, though I will say none of this is ever set in stone. We're constantly reviewing this, and we may well change it or tweak it as we see fit. But the original design and the way we wanted to use this was primarily as a triage service. And we wanted to try and triage that the decision would be that either this patient needs to go to the 2-week wait, or this patient is okay to stay in a monitoring capacity, and we don't need to be concerned at this moment. They are very borderline, but they're still not showing any significant clinical symptoms. The final group is the low risk group, where we really see no evidence that this patient has myeloma or has any evidence of serious progression in their monoclonal, and therefore we're going to put them onto a database, and they're going to go into periodic monitoring. Now, particularly with this group, what happens with that is, actually, I'll go and talk that through as we go through it, because I've got some details on that. So if I just pull up on this slide here, what we do to identify this patient is we have algorithms in place where we use all three. We use urine electrophoresis, serum free light chain, and serum electrophoresis and immunoglobulins. And we've done lots of work on this over the time. We have some published work on changing serum free light chain ranges to be able to help get every patient that we run through this system assigned to an outcome, so that we don't end up generating lots of patients with grey results. And this is one of the things people criticize about this pathway a lot, is you end up generating a lot of patients. The harder you look for a monoclonal gammopathy, the more aberrant and abnormal results you produce that you don't really know what to do with. So we've spent a lot of time trying to work through all of those aberrant results and come up with what you should do in these scenarios. And we've done that by just running a lot of samples and auditing it, and doing a lot of clinical audit and coming back to what do we think are the relevant PPVs and NPVs of the results that are being shown. And I want to show you again this screen that you've seen once before, which is showing you the different criteria for selecting patients into those different outcomes. Now, we worked on this with hematology, and I want to make it abundantly clear, this is not lab immunology just making something up and implementing it. From the get-go, this has been a collaborative effort. We have worked with the clinical users, and particularly hematology, because clinical hematology care for these patients if they go into these higher level outcomes. And so it's important that they are on board and they agree with what is being done. Otherwise, we're going to be disjointed, we're going to be siloed, and the system will not work. So we set this criteria up, and this gave two things. It gave lab immunology the confidence and authority to be able to implement decisions without having to get them second checked. It gave clinical hematology the peace of mind that the process was being done correctly and effectively, so that they knew that the right patients were coming to them, and that patients weren't being overlooked or misdirected. Okay, so if we get a patient that comes into outcome 1, we had to think a lot about the mechanisms of how that works. And so there is a lot of detail that needs to be thought about when setting up a care pathway like this. You've got to think about the flow of the patients. You've got to make sure that information is being fed both to the people who are going to care for the patient as well as the patient themselves. And one of the things about this part of the pathway is that although the GPs were going to be supported by this process, the patient is very much still being managed by the GP. And so I've had to be very clear that this is a support service for primary care, This is not a secondary care service with regards to the low risk MGUS arm. And so the very first thing that needs to happen is that wherever the test request has been made originally, whether it was made by the GP or it was made in secondary care because the patient was visiting an outpatient clinic, that the GP will be notified by the low risk MGUS team that the patient has a new monoclonal gammopathy, but it's been risk stratified as low risk, and that they will be placed onto a database to schedule any further monitoring. At this point, the GP is directed to a resource page that we've set up on the hematology workspace, and that gives the GP information about what to do next. It gives them information about how to communicate the news to the patient, what kind of things need to be said to the patient, and what the key messages they need to put across. And it also says to them what to do if the patient comes back to them with new symptoms in the interim before their next monitoring period, and what to request and how. What importantly is the patient going to be told? So we've set up a few letters, and in all of those cases, the letters have gone through patient groups or are currently going through patient groups for further approval on later versions, to make sure that the Oxford Blood Group, for instance, are happy that the patients are able to understand the information that we're putting out. Here is one version of one of the letters. This is the welcome letter that will be given a period of time after we first find a low risk MGUS. We want to give it enough time that the GP has time to be able to talk to the patient first, which is the instruction we give, and then this will come to the patient. It will be distributed via EPR and logged on the records, so we've got good data collection. And the three messages we really want to put across to the patient is this is a low risk condition, and it's unlikely that it's ever going to cause them problems, that they remain in the care of their GP at all times, and they should always talk to their GP rather than try and find a way of talking to the secondary care group. And we've tried very hard to make sure that that's in place, because I have seen experiences of other systems where the patients become reliant on being able to always talk to a myeloma nurse, for instance. Now, that's no bad thing. That's lovely that we do that for the patients, but actually it's probably not the best use of the resource, because there are whole groups of patients who really do have quite severe myeloma ongoing and are on chemotherapy who need that myeloma nurse support more. And then the final part message is to make the patient aware that there are some key symptoms that they shouldn't ignore. And if they do get those symptoms, that they should go to their GP so that those interim tests can be performed. Now, the patient's placed on the database, and the database is not complex. It's a very simple database, but it's a robust database that allows us to be able to pop up patients and notify them whenever they are ready to be monitored, and that will trigger a letter to notify the patient that they're having bloods taken. So they receive a second letter at the point of monitoring that says they need to go to their GP surgery and have their bloods to be taken. And actually what that letter includes is it includes a set of instructions for the GP surgery. So what we're doing is saying to the patient, take this with you, go and take this to the GP, and you haven't got to remember what to ask for. You haven't got to deal with any tubes. The GP surgery will collect the tubes and put it through their EPR system, because we've given them a full SOP that comes with the letter that they can take, which tells them what to click on and which to do. And I'm hopeful that we'll refine this even more and potentially restructure our ICE system that we use in Oxford for the GPs, so that it really is just one button that they have to click. And that's what I aim to do. We haven't got that in place yet, so that's why it's a little bit more detailed about what we're doing. When the monitoring bloods come in, the lab immunology team will pick them up during their routine authorization, and then we're able to do a second set of criteria to be able to understand if that patient has progressed or is showing evidence of progression. And if they are, we will contact the GP, and tell the GP that they need to now refer the patient through to hematology and inform the patient that they're doing so. If there is nothing to progress on it, then that will trigger us to send a letter to the patient as a third letter that says, your results have come back and they're completely fine, and please continue to be vigilant about your symptoms, but otherwise carry on to lead your life as normal. So this is the setup that we've run. Now, one of the questions that came up from the LMC when we were doing this was, what are we going to, this is prospective recruitment to this pathway. What about the existing cohort of MGUS patients? And the work with the CCG was agreed that we would do some retrospective patient acquisition into this. And we agreed that we would take all patients from 2018, 2019, and 2020 that were found through the Immunology service and place them into this database. Now, that has well, we've been working on that during 2020, to be honest, and we've been taking that data, cleaning it, identifying those patients, making sure we have the right ones, working out which surgeries they have, and compiling a surgery by surgery list for the Oxfordshire CCG, because what we can't do is just add them all on the same day and implement their timelines, because that means that one day my protein bench will receive potentially 10,000, not 10,000, exaggeration, 1,000 monitoring bloods all at once, which they will not be very happy with, and they're often not happy with me anyway. So we've tried to try and stagger this. Our strategy is that we're going to do clusters of surgeries during 2021 and bring them online slowly, so that we're having this rolling workload bringing through. There will be two types of letter. One of those letters will either be welcoming the patient onto the pathway and saying, you know, your GP is aware, and if you need to have a conversation, please do. And the other one will be a welcoming letter that also asks them to immediately go in and get a monitoring blood. One of the things that, as I bring back to my story that I told you earlier about the patient, is the general compliance with the current instructions that we're giving for doing monitoring is not working 100% by any stretch. We're doing some data on 2014 work at the moment that we have, so those patients have got 6 years follow-up. And just as an initial stat, 30 to 50%, about, between 30 and 50% of the patients that we found in 2014 that would be what we call outcome 1, the lowest risk, have never been tested subsequently since 2014. We have no evidence of ever being brought in again for a monitoring blood. So the problem we have is that the monitoring adherence is poor, and this is our strategy to try and bring that back up as best we can. It's not going to be foolproof, because patients can choose not to be monitored, but this is our attempt to try to make sure that we can get it going as best we can. Okay, I'm going to wrap up there. I think I'm approximately on time. One of the final sets to talk about is how we disseminated this information across the hospital. And we had to disseminate a lot of information across the different clinical teams, particularly clinical hematology, which is a vast team of people. And there are lots of junior registrars and lots of different consultants, lots of people manning different clinical advice emails, which can receive various queries about MGUS or the myeloma pathway. And one of the things that I was very desperate to try and stop is disjointed messages, trying to get a unified system, a unified protocol, and trying to get that out across a number of people, particularly in COVID, is very tricky. And the way I tried to do this is to set up some YouTube talks. I found, if anyone, generally as a side point, I found YouTube incredibly useful during COVID, and to create talks for people. My team, if there's any of them listening, will roll their eyes, because I've basically set up seasons like Netflix of different CPD talks of immunology, which they can access and do. If anyone wants them, by the way, contact me, I'll give them to you for free. But you can use it very, very well to be able to get information out, because people can watch it in their own time, and they can watch it at their own pace, and they can keep looking at it again and again and again if there's something they're unsure about. We did set up an nhs.net account, and that we've asked for people to triage their own advice emails to pull in all the relevant ones to us, which has been very useful. When I did this talk, I'm just going to stop this quickly. But when we did this, one of the things I want to point out to you is whenever you set a talk up for people, make sure you have at the front end a 2-minute executive summary of that talk, because there will be a contingent of people who will only watch it for 1 or 2 minutes, and then they're going to turn off, and there will be a group of people who want every single bit of detail possible. So set the talk up that you do something for 2 or 3 minutes, and then you subsequently move on and do the rest. That would be my advice. Some people have said to me, you should set 2 different talks up, one that is only 3 minutes and one that is 35 minutes. And I do think that's fair as well. So whichever way you think works for you, but try and think about delivering your information in 2 different ways for the 2 different types of people you've got. So thank you for listening. I hope I haven't gone through too fast, but just to summarize, 2020 has really bucked the trend seen in immunology test activity for the last 3 to 5 years, and we've seen a decreased activity overall. That decline is seen in all areas of immunology testing, and with regards to screening programs, we've also seen that reduced, and we've seen a reduction in positive patients that we would statistically expect to see. It's hard to quantify what that impact will mean on patient mortality, but if we are talking about the myeloma setting and those outcome threes, those high risks, we haven't seen enough of them. And therefore, I suspect they're going to present. And if they're presenting, they're going to present in a more acute setting, which is not a good thing. It's also 2020 has put a lot of pressure on development of care pathways. We've had to refocus a lot of our resources, but identifying proposed developments that can yield benefits, especially in the pandemic era, has been really important. Certainly I've really tried to work on is trying to, without sounding too cliched, make some lemonade out of the lemons. And I've tried my hardest to see a way of being able to make us stronger post this period of time. And this idea that we've set up is a support process for primary care to monitor low-risk patients and to risk stratify them. And it will also help secondary care. It helps us try and help control their 2-week wait clinic workload, because we know technically who should be referred in. So if someone is getting referred in who shouldn't, it allows us to engage with those users and try and talk about why they're referring, and probably most likely just educate them. That's probably all they will need. Just some quick acknowledgements, but thank you very much for this time. I just want to acknowledge various people who have helped us along the way, particularly the myeloma nurse team and my MGUS pathway coordinator that we now have funded, called Sharon. We've got Grant, who's helped me with the resources. Lauren is my PhD student and one of our healthcare scientists who did a lot of work chugging the data for me. I'm very grateful. And then I've got various other people, such as the heme teams and some GPs as well. But thank you very much.
That's brilliant. Thank you very much, Ross. We've got a few questions to get through, so I'll just get started. The first one is, did you see an increase in positive ANA results in patients with COVID?
Yes, we did. We did see a positive, definitely. And the problem is that the reason why I didn't pick ANA in this talk to bring up is because it's got such poor specificity for any one disease that actually it would have given the inverse, which is that we would have probably seen an increase in ANA positives rather than a decrease in ANA positives. And actually the ripple effect of that down your investigation pathways is not to be ignored, because you've put yourself in a situation where you now are to some extent compelled to have to do further investigations of ENA screens, DNA antibodies, and again, spurious positives are most likely being increased. So yeah, the answer is yes. This is a highly inflammatory scenario. So we are seeing these. How to manage it, I don't think is easy to do, because you don't always know if the patient is COVID positive at the point of testing. So it's very difficult to manage.
Okay, thank you. Next question is, have you assessed the new staff scheduling for their effect on any key performance indicators such as turnaround times?
Sorry, can you say that again?
Have you assessed the new staff scheduling for their effect on any key performance indicators such as turnaround times?
That's a fair question. So our turnaround times significantly increased or improved, I should say, during 2020, mainly because we had less work. So the biggest reason why we were able to cope with the workload is because we have less of it to do. As it's climbed back up later on in the year, this is where we're really starting to look at that change in working practice. I would say that the balance of this is, our turnarounds are doing okay. They're doing fine. They're doing no worse than they were doing if I take January or February of 2020. But I guess the difference is the members of staff who are working these different shift patterns have done so because it flexibly improves their quality of life. So if I want to talk about it from a point of a happy worker as a productive worker, there is an element of this which has helped us be able to help different members of staff with their lifestyle. And everyone's lifestyle is obviously, I'm doing this presentation from my study, for goodness sake, so that gives you an indication, doesn't it? And I'm not doing it in a room, so everything about life is different.
Thank you. What have you learned from this experience with regards to developing care pathways?
So the biggest thing that I guess I've learned is nothing that isn't already said out there, but it just emphasized how important it is. You need to bring everyone on board. You need to talk about to all the various people that are going to be involved. So we've had good dialogue with the GP community. we've had good dialogue with the patient community, and we've had good dialogue with the hematology groups, and that's nurses and consultants, because nurses and consultants' perspectives of a clinic are very different. They deal with the clinic in a very different way, and they deal with the patients in a very different way. So I've made sure that we've involved everyone as much as possible, and also made sure that everything is open to change. So we don't put anything in, we fix it in stone, we try and put it, and we open it up to edits, and we open it up to versions. And those, I think, have been the biggest things that I've realized you've really got to do. And data is key. You've really got to make sure you have a good handle of your data, and you put it in an effective pipeline of, if you have multiple people help you, make sure you work together and you know which stage the data's at.
That's great, thank you. Do you think there's a wider role for healthcare scientists in these areas of care pathways?
I do. I think what you have to be very careful. I don't want to be a person who says that healthcare scientists need to take over the world, because that's sometimes the message that can come out from this sort of question. I believe that there is a role, in the same way as I think there's a role for all the different healthcare professions, but what we tend to see sometimes is a mixed collection of professionals running this sort of care pathway, but none of them are scientists. And so the scientist in that situation naturally brings some good analytical skills to that. They have good data management, they have good systematic approaches to work, they can see details and mechanisms sometimes that others may not notice. And that is, as I've said to people many, many times, if you've got a job that requires someone to look at a screen of numbers and make decisions on an algorithm, pretty much that's what scientists were invented for. So we are the best equipped to do it. It doesn't mean other people can't do it, but that is a real strength for us. So I think that's something that should and could be better utilized in healthcare. Okay,
brilliant. Is the decline in new diagnosis of autoimmune disease same for ANCHOR and GBM?
So the ANCHOR and GBM part, to some extent, we've seen, again, a problem of it being caught up in COVID. So we've seen lots of ANCHOR positive patients and NPOPR3 positive patients coming out of COVID areas because of this inflammatory effect. So it's very hard to see that clearly, again, for that reason. I think the only way you'd be able to do it is to really link up with someone like renal and respiratory and look at biopsy data and try and really check and follow through the patients to that level. So it's a very hard one to answer. The GBMs, I haven't got a handle for whether we've seen a decline or not, unfortunately. Okay, that's great. You'll have to excuse my pronunciation in this question. Okay. Hopefully I'll get it okay. Is your monoclonal gammopathy risk model published anywhere? So our stratification table is not published yet. What I will say is that Myeloma UK recently issued a set of lab and GP tools that are currently going. If they haven't been fully issued, they're on the way to being issued. We've certainly issued a GP one. And myself and Karthik Ramasamy, who's our myeloma lead, are both involved in various committees and the Myeloma UK boards to set up these tools. And we have a set of criteria that is similar to what I've shown you today. The Oxford one is slightly more involved and slightly more tweaked, but it has the same fundamental principle to it. I'm happy to share it with anyone. If they want to get in contact with me, I'm more than happy to share it. Nothing I've shown today is protected. So there is lots of opportunity here for shared learning. Brilliant, thank you. Monitoring MGUS, do you not use advisory comments on monitoring in your reports? We do, and we have for a number of years, for 3 years, in fact. And so if I give the example I had of my patient I talked about today from 2018, who was discovered in 2018, that had advisory comments on it. And what we've got here is a situation where the advisory comments have not been followed through. So I guess we need to be realistic about is an advisory comment is exactly that. It's an advisory comment. It's advising and saying, this is what you should do or what you could do. It doesn't mean that you've empowered it, that it's definitely going to happen. And what I also want people to realize is that unless you have a really, really good handle of your IT systems, do you 100% know how those comments appear to the user who's going to receive them? Because I can tell you now, in Oxford, our EPR system in the hospital throws immunology comments all over the place. And so it is sometimes of no surprise that our clinicians don't see the comment that we've lovingly constructed and told them what to do. They don't know where to find it. So yeah, it does work. But you know, the age-old thing is urine electrophoresis. Asking for urine electrophoresis from people as a comment. We've never achieved greater than 50% compliance for getting urine. So it has a long history of not being that effective.
Okay, thank you. Does the letter calling up patients for monitoring go directly to the patients or to the GP surgery, or both?
So the welcome letter I showed goes straight to the patient, but there is a time lag, so that the letter will not be sent out until 4 weeks after the GP has been notified that the patient has a new low risk MGUS. And what we're doing in that period of time is giving the patient or the GP enough time to be able to read through the instructions on our website and to be able to discuss it with the patient. Again, I don't think this is foolproof. I can't guarantee that the GP will do it 100%, but we have tried to set up a system that means that it should hopefully start to bear fruit, and we can educate anyone who fails on any one of them. The letter will always encourage the patient to talk to their GP though, and to discuss it if they're worried. We do put resources on there to Myeloma UK as well if they need to, because Myeloma UK does have some good MCUS resource.
Thank you. How much do you use commenting on EP reports to guide subsequent and ongoing testing?
So with regards to the monitoring, the actual the system that's designed will be that we will say very little if we feel that there's no need to. So if we feel that there's nothing progressed or changed, then really the message back to the GP is going to say this patient's going to continue to be monitored, because the project management or the scheduling of that monitoring is still being controlled by the low risk database. So the GP just gets a confirmation that says your patient was monitored and everything's fine. The patient will be told you were monitored and you were fine. If something serious has been found, then we will contact the GP ourselves. Now, from a kind of workload point of view, we don't envisage this being a lot of work, because the rate of progression in this cohort is very low. It's, you know, it's at most 1% per year. So it's not going to be a large number of phone calls or anything to do. But when it works, it's great. And it's really worthwhile.
Okay, brilliant. We're running out of time, but there's just a few more questions that I'd like to run through quickly before we log off, if that's okay. Can you comment on the work you had to do around clinical governance, particularly where the lab is effectively making a decision on patient care?
So this was, again, about getting everyone to agree up front. So this was about a conversation. We did have conversations with the commissioners in the OUH hospital who were working with the CCG on this. And we also had lots of conversations with various clinical leads. So as I said, I've got the myeloma clinical lead and I have the overarching clinical lead of hematology in firm agreement about this structure. And that's where your governance comes in, is around the normal clinical groups who are involved in these patient care of these patient cohorts being happy with the structure and the documentation and the framework in place. So this is very much why, again, I've said that it's about involving everyone from day one and putting in the proposals. When you put the proposals in, and I can remember this at the very beginning, if you say to a group of people, hey, I want to be involved in your care pathway and I want to make loads of decisions and I want to do this and I want to do this, their innate feeling for it is very territorial, and they'll say, why are you interfering with my work? Get out of the way, go away, bugger off. But you need to be able to pitch it and say, it's here to help. These are the benefits I can bring. This is why it would help you. This is what I think we could do as a team. And actually that then completely changes how everything's approached. And actually, I haven't, you know, everyone's been very positive, I'd say, in our experience.
That's great. Is the algorithm for risk stratification automated or rely on BMS, clinical scientist or medical staff review of individual results to make a judgment? If manual review, what level of staff do this?
Okay, good question. So is it automated? It isn't automated in Oxford, and that's because Oxford at this point in time has one of the oldest LIMS systems in existence. Our system was coded in about 1978, and that's not an exaggeration. And we are currently hoping to go through some new LIMS development in our network soon. And if you have a newer system, if you use something like WinPath, I do believe that WinPath will have some automation programming that could be utilized to help with this. It will not do all of it, but it could help remove some of the volume for you and make some of the background checks complete. What level of staff do it? The level of staff that we use are, in our lab, we use 7s and 8s to do authorizing and checking of results. But I don't see a reason why some of this couldn't be flagged at the 6 level, or even the 5 level. If you've got someone keen who can show that they can do it and you can train them properly, there is no reason anyone who's state registered couldn't make some impact on these decisions. This is about filtering. You've got high workload coming through and you need to make decisions. Some of these decisions will be barn door and easy. So we have at the bench level critical alert values. So things that may trigger an outcome 3 from the people on the bench who first generate the results. If they see one of those flags, they know that they need to phone the result out. So we can have some of it run at that level. It will be the patients who might, do they need to go to outcome 2? Those sorts of questions might need a little bit more thought. So it would be pushed up to higher grades.
Okay, thank you very much. Unfortunately, that's all we've got time for today, but hopefully we've managed to answer most of the questions. And thank you very much for an insightful presentation. Hopefully you've all enjoyed it.